All right, we're completely bypassing the pleasantries today and jumping straight into the high-yield pathophysiology of catastrophic right-sided hemodynamic failure. You are stepping into a clinical explainer that's been meticulously calibrated for deep integration. We're talking 270-plus level material here. Our focus today is breaking down the intricate mechanical barriers that literally choke off cardiac output. We're going to isolate the exact differences between two incredibly deadly presentations, pericardial tamponade and constrictive pericarditis. So let's deconstruct the exact mechanical forces that prevent the heart from filling when it's under extreme clinical stress. When we talk about impaired diastolic filling, we're really examining a heart that is being strangled from the outside. But here's the thing, the actual nature of that strangulation completely alters your diagnostic markers and your discrete management steps. Is it the crushing hydrostatic weight of locked fluid, or is it the unyielding grip of a fibrotic shell? Mastering that difference is absolutely crucial for your clinical practice.
Module 1. Pericardial tamponade kinetics.
Okay, the really crucial point here is that it's the rapid rate of fluid accumulation, not necessarily just the absolute volume, that drives this hydrostatic collapse and completely compromises ventricular filling. As fluid rapidly pours into a relatively inelastic pericardial sac, that pericardial stretch limit is surpassed very quickly. And once you cross that threshold, the intrapericardial pressure shoots up and becomes critically elevated. The heart is effectively drowning in its own confined space, totally unable to expand and receive venous return. That classic water bottle configuration you often see on a chest X-ray is a massive signal. It tells you there is immense fluid pressure locked right within that inelastic pericardial sac. Now, while this massive globular silhouette is a profound visual marker, keep in mind that tamponade can actually happen with much smaller effusions if they just accumulate too fast for the sac to stretch. But when you do spot this extreme cardiomegaly, combined with completely clear lung fields, you are looking at the radiographic hallmark of a massive hydrostatic lock. Now, what's really fascinating here is the precise timing on echocardiography. The right atrium collapses during systole and the right ventricle collapses during diastole. That timing strictly confirms the diagnosis. These echocardiographic mandates aren't just showing general compression, they are cycle-specific. This confirms that the external fluid pressure has actually overwhelmed the internal chamber pressure during the exact moments those specific chambers are supposed to be at their absolute lowest pressures. Because the outer sac is entirely fluid-locked and refuses to yield, the heart has no choice but to adapt internally. So think about inspiration. The negative intrathoracic pressure pulls in more venous return to the right heart. The right ventricle tries to expand to accommodate that extra blood, but with the external fluid acting like an absolute brick wall, the expanding right ventricle strictly bows the interventricular septum inward, forcefully impinging on the left ventricle, and that drastically drops your left ventricular stroke volume. And that strict pressure drop, that defines pulsus paradoxus, which is an absolute high-yield marker for tamponade physiology. Because that interventricular septum is being shoved into the left ventricle during inspiration, the stroke volume plummets, causing an exaggerated drop in systolic blood pressure of greater than 10 millimeters of mercury. If you encounter hypotension, muffled heart sounds, and jugular venous distension, Beck's triad, combined with this exaggerated pressure drop on inspiration, well, you are looking at an absolute mandate for emergent pericardiocentesis. Module 2. Constrictive pericarditis and fibrosis. Let's contrast all that fluid with a totally different beast. Unlike fluid accumulation, this condition is driven by a rigid, fibrotic, or even calcified pericardium. We're usually talking about a history of prior radiation therapy, cardiac surgery, or tuberculosis. This completely restricts late diastolic filling. A CT scan will map this anatomical progression perfectly, showing an unyielding shell. Over time, the sac scars and calcifies, creating a strict anatomical barrier that essentially locks the heart in a rigid cage. Because the right heart just cannot accommodate the increased venous return during inspiration, the jugular venous pressure paradoxically rises. That delivers the classic Kussmaul sign. The right heart tries to fill, but it slams right into this rigid barrier. And if you listen closely, you aren't going to hear the muffled sounds of a fluid effusion. Instead, you'll hear a pericardial knock. It's a high-pitched, early diastolic sound produced when that rapidly filling ventricle aggressively collides with a calcified wall. This high-contrast diagnostic decision matrix is fantastic because it aggressively isolates two identical presentations of fluid overload. They look the same on the surface, but they diverge completely based on singular systemic variables and highly discrete management steps. Both give you elevated JVP and decreased cardiac output, right? But observe the variance. Tamponade presents with pulsus paradoxus and Bextiad, strictly mandating emergent pericardiocentesis. Constriction, on the other hand, gives you the Kussmaul sign and a pericardial knock, which is managed eventually with a surgical pericardiectomy. Module 3. Right heart catheterization tracings. We're getting into the really intricate stuff now. In tamponade, because that external compression from the fluid is continuous throughout the entire cardiac cycle, we see an absolute equalization of pressures. The sheer hydrostatic weight essentially erases the normal pressure gradients you need for efficient forward flow. The heart is being uniformly squeezed at all times, driving equalization across the right atrium, right ventricle, pulmonary artery, and the pulmonary capillary wedge pressure. So the real key to differentiation here is contrasting the blunted Y descent of a fluid lock against the hyperprominent descents of a fibrotic shell. In tamponade, that continuous fluid compression severely impairs the right atrium's ability to empty, so you get a strictly blunted Y descent. But in constriction, early filling is completely unimpeded right up until it hits the rigid wall. This drives remarkably prominent X and rapid Y descents on the right atrial tracing, giving you that really distinct M or W shape. This brings us to the dip and plateau, which is the absolute hemodynamic signature of early, incredibly rapid diastolic filling colliding violently with the calcified pericardium. Tracking the ventricular pressure curve in constriction, we see the pressure dip because early diastolic filling is uninhibited, but it's so rapid that the expanding ventricle abruptly hits that rigid fibrotic wall and the pressure violently plateaus. This strict square root sign is the exact mechanical translation of a heart colliding with its calcified cage. Module 4. The master case. Deep integration. Let's synthesize all these strict pathophysiologic mechanisms into a master case blueprint. We're tracing a patient presenting with catastrophic right-sided hemodynamic failure, specifically with a history of remote oncologic therapy. Our patient is a 55-year-old female who had chest radiation 10 years ago. She presents today with severe progressive ascites, massive peripheral edema, and severe jugular venous distension that noticeably increases when she takes a deep breath. She's profoundly volume overloaded, and her right heart is failing to accommodate venous return. Now, you have to beware the diagnostic trap here. The completely clear lungs are going to heavily mask the underlying constrictive pathology, trying to push you towards something like COPD or pulmonary hypertension. You'll see a clear chest X-ray, totally normal lung fields, alongside a massive, enlarged pulsatile liver. It aggressively mimics cor pulmonale. The entire trap is designed to pull your attention away from that fibrotic pericardial shell and trick you into treating a non-existent primary pulmonary etiology. Your assessment execution has to strictly demand the identification of the expected right atrial pressure tracing, those prominent X and Y descents, from a tightly calibrated, exactly 5-option matrix. To conquer this, you must recognize the remote oncologic therapy and that Kussmaul sign, isolate the diagnosis of constrictive pericarditis, and strictly select the precise underlying pathophysiology of impaired diastolic ventricular filling. You've got to confidently blow past those highly competitive distractors pointing to cor pulmonale or tamponade. Mastering these hemodynamic crossovers ensures you don't just memorize the markers, but you definitively command the underlying physics of a failing heart. Ultimately, when you're standing in front of a rapidly deteriorating patient, your ability to instantly distinguish between the hydrostatic weight of a fluid lock and the unyielding grip of a fibrotic shell will dictate their survival. So, when that right heart begins to fail and seconds count, will you recognize the true nature of the cage?